ahead with another hip case, which is also a long case.
Good morning, everyone. I'm Dr. Dhruv Paul, third year orthopedic resident from Sion Hospital. I'll be presenting a hip case. She's a 10-year-old female who comes with chief complaints of pain, limping and pain since the last 3 months. Informant is the mother. The pain has been pain was started after a history of trauma, which occurred 3 months ago. So it has been increasing. The pain and the limp has been increasing gradually since 3 months.
How significant was the trauma? Was it a trivial trauma or a significant
trauma? It was a trivial trauma, ma'am. She had just a history of fall.
This is important here because the pain has started, you said, after the trauma. So is it just an incidental thing, or is it significant, a post-traumatic condition, or trauma was just incidental is important. So you have to say whether it was a trivial trauma or a significant trauma. Significant means a trauma which required her to be immobilized or she was not able to ambulate after that is a significant trauma which points you towards something in the fracture or some significant problem. So important here.
Yes.
Okay.
So it was a trivial fall, so nothing like related to traumatic anything. So the pain has been increasing and the limp has been increasing gradually since 3 months. While she walks, the pain is increasing, but while she rests, it decreases. The pain is mainly present in the groin region, but it doesn't radiate to in the thigh or the knee. The limp is always present.
Pain enough. Pain has lot of characters of pain, which points you, which makes you towards, takes you to some diagnosis. So does she have any night pain? Does she have mechanical pain? Is there any diurnal variation?
There is no diurnal variation. There is no night pain. The pain is mostly a dull aching one. While she walks, then only the pain occurs. Other than that, ma'am, there is to rule out other diseases. There is no history of fever. There is no history of night pain. There is no history of evening rise of temperatures. There is no history of morning stiffness. There is
okay, so now the next complaint is limp.
Yes, ma'am.
So describe something about the, this is a long case, right? So yes, we have to describe in detail.
Ma'am, the limp is of 3 months duration. It started occurring only while after she had a history of fall. It always occurs while she walks.
It's a painful limp or a painless limp?
It's a painful limp to begin with. It never had that painless character. It was always painful.
So is it painful now? She walks with a painful limp at present?
She walks with a painful limp now.
Okay. Why is it important to know whether it's a painful or a painless limp? What are the conditions which will give you painful limp and painless limp?
If there is transient synovitis of hip, there will be a painful limp. If there is septic arthritis, it will be a painful limp.
3 months transient synovitis will lead to 3 months of painful limp? What is the classical thing in a Perthes disease?
Ma'am, in a classical Perthes disease, the limp will be first painless and gradually it will become painful.
Why should it become painful? Painful means there's some sort of arthritis there, yes, okay, which is a very late sequel where you have, or there is some infection, inflammation, something. Now you're talking about something non-infective condition. Only if there is an episode of subchondral fracture, that is the time in Perthes you get a painful limb. Otherwise, classical Perthes is a painless limb. Unless it presents at a very late stage where it has developed arthritis, then it will be painful. So a classical description of Perthes is a painless limb. So many times once you know the diagnosis and you have examined and you have come to something, you have to fit your findings into going to the diagnosis. Otherwise you will go haywire, then you can't justify why you are saying.
The other thing is, as madam said, you said his limp has started after a history of trauma. in pediatric orthopedics, especially in pediatric orthopedics, in any condition of the limbs, they will always say that there is a history of trauma. So it is up to you to know whether that history of trauma is significant or not. So you should ask them, when she had that alleged history of trauma, on the same time did she have pain? Was she taken to the hospital? Was she able to sleep at night on that day? Or was she able to do her daily activities at that time? Only then it shows to the examiner that you have thought of that process. Otherwise, again, you are saying that the limb started after trauma. It didn't start after trauma. It may have started if you ask the history, it is after 1 month of trauma. Or whatever. So
mostly the two events are like simultaneously only. Like she doesn't give any history like after trauma, like 1 month she is limping. They are ongoing.
Then you have to be smart enough to say something. You can't. Parents are not always there to check for minor limbs and all. They will direct everything to that particular event. But you should be able to formulate and come out with a proper history so that it flows towards the final diagnosis. Okay. So if you have said that it was a trivial trauma, non-significant trauma, then this was noticed, but then limp and all gradually occurred when the patient became more painful or the disease progressed.
Okay.
So don't complicate in such minor history. See, because if you waste more time in this, then you lose out on your actual clinical examination and discussion of the thing. So be very clear. Most of the time you know what the diagnosis, what the history would be, that should be ready, and then just take plus minus and it should be a flow. Should not waste time, little bit here and there from person to person, but otherwise the histories and things remain the same for everyone. Should be able to discuss more on the actual thing, the actual test, discussion of the pathology. And
then the management. So our aim of your aim of the presentation should be to be able to reach a good diagnosis with minimal, in a way, interference from the examiner, so that you should not say something which is objectionable to the examination findings, and then you should be able to discuss the management more, rather than go on and about small points of the
So just history in this patient is pain and limb, that's it. Okay. Yes. And no other significant causative history. No. Okay. So let us go to...
So is she able to do activities of daily living? Is she able to do...
She is unable to squat and sit cross-legged. Just
she is unable to sit, unable to squat also?
Yes. Other than that, there is no restriction of any daily living activities.
खाली बसू नाही शकत, टॉयलेटला खाली बसू नाही शकत, क्रॉस बसते.
From the history, what are you thinking of?
Like she is a female of age 10 years, presenting with a limp. So most probably the diagnosis will be leg calvi Perthes disease.
What?
Leg calvi Perthes.
Directly from the history?
Most probably, ma'am.
So most probably it's a pathology. Something involving the hip. So it is a it is a case of
so you said
synovitis.
Female. You said something about female.
Yes.
So that's why most probably it is Perthes disease.
It has a female preponderance, and age group is also.
You think so? Perthes has female preponderance, or DDH has female preponderance?
In fact, Perthes has a overwhelmingly male preponderance.
Because of a particular type of blood supply, that ring which is deficient to some extent in males at particular age, and she is also old age. She is not 10 years or late onset Perthes. They come little earlier.
So typically DDH is female preponderance, and SCFE and Perthes is very widely male preponderance. All right. So again, you missed that point when you said female, and that's why Perthes. Again,
when
it doesn't make sense.
See, examiners will ask you at the end of history, what is your very, very probable diagnosis. So in this case, whatever positive points, a 10-year-old female coming with a history of 3 months of duration of limp and non-significant pain with a functional disability, I am thinking something like a synovitis of the hip, The probable etiology could be Perthes disease or a second etiology, Cox. In our case, our country, you have to put some differential. Because
Okay.
that,
Assuming your diagnosis of Perthes disease is correct, just from the history, what do you think would be the prognosis in this particular child? And why? Just on the basis of your history points and this patient profile.
Sir, first I'll like to take note of the age of the patient.
Yes. So,
Like females reach skeletal actually maturity at an earlier age. So the time for the femoral head to go through that natural history of uh,
so age and female sex. So from the history, these 2 points are poor prognostic factors if we assume that your diagnosis of Perthes disease is correct.
Yes.
Okay, fine. Go ahead.
Next I'll proceed with the general examination. In general examination, she doesn't have any anemia. Build is normal. There is no history of icterus. There is no swelling of lymph nodes or anything. I'll proceed with the local examination. In local examination, first I'll start with inspection. Yes. I've inspected the patient in supine position and in standing position. In standing from the front, from the side and from behind, and in supine position from the front and from the side. In standing position from the front, the head is centrally located. There is no neck tilt. The level of shoulders is both shoulders are at the same level. The chest wall, chest are symmetric on both sides. The level of anterosuperior iliac.
local examination, and even if you are describing, no, this should be very quick because orthopedic surgeons not interested in level of shoulder, nipple, chest, everything, one line, fatafat, everything is normal coming to local examination. Yes. Okay, unless there's anything specific, even that pallor, anemia, icterus, all that should come in just one line. Very quick, averagely built, nourished, no, this, and then coming to local because all examiners are interested in local. So come to local examination in supine position. Tell us, what is it? In hip case, what is the level of both anterosuperior iliac spine?
Both are at the same level. The level of greater trochanter is also at the same level. And ma'am, there is no exaggerated lumbar lordosis.
See, in this case, it's a long case, and in this case, even the negative finding is important. That there is no shortening which you have felt. There is all the levels of bony markings are equal to other side. There is no lumbar lordosis. There is no obvious flexion deformity. So all these points are important to tell, na? And you should know what are the points to tell. So you can't just go all about around the bush and then say that go to palpation findings, na? You should be specific about what you want to rule out by saying a few negative points, na? So what are the negative points which you want to say quickly?
Sir, since there is no exaggerated lumbar lordosis, so we can rule out fixed flexion.
You just say there is no exaggerated lumbar lordosis, no obvious flexion deformity. The greater trochanter is at the ASIS is at the same level, greater trochanter at the same level, the medial femoral condyles are the same level, the ankle is at the same level. Yes. Okay, there is no shortening?
No, sir.
Okay. Next, what will you look? There are no obvious scar sinuses?
No, sir.
Anything else?
Any wasting?
No, ma'am. There is no wasting of the thigh or the calf muscles.
You are sure?
Yes.
You have measured? You don't want us to come there and measure, no? Pakka?
Palpation now. Anything in palpation?
Ma'am, on palpation, I'll start with the temperature. The temperature on both sides is normal. Tenderness, there is tenderness of the pubic tubercle, ASIS and GT. And next, ma'am, on palpation, I've drawn the
So tenderness is there on the pubic tubercle,
Yes.
ASIS and GT.
Yes.
Okay.
Ma'am, sir, it may be vague, but she is complaining like.
Palpation is not what she is, tenderness is what you are checking. She is complaining means what have you checked? How have you checked? Usually you check the anterior joint line or any greater trochanter. Pubic tubercle means there's some focus there of some infection which, involving that area.
So again, these findings don't make sense, no? So you are saying pubic tubercle tenderness, you are saying ASIS tenderness, you are saying GT tenderness, and you are not saying anything about the anterior joint line, you are not saying anything about the femoral triangle. Is there tenderness in the femoral triangle? Not checked. Okay. So again, he is describing an intra-articular pathology, intra-hip pathology. So the important thing is that you have to check for the tenderness in the femoral triangle or the anterior joint line of the hip. GT tenderness or pubic tubercle tenderness or ASIS tenderness again is not relevant in this case, right? So you should be very specific about what exactly. So you should have a mental picture about what you are thinking of, and probably go ahead and fashion your entire examination and history around that. Not making it too obvious, but you should be logical in your thinking, right?
Ma'am, on movements, on checking the lens,
Checking the what?
length, ma'am, measurement.
अरे movement पूछा तो measurement कहाँ पे आया है?
Sir, on movement, the right-sided hip has restricted abduction, internal rotation and external rotation as compared to the left-sided hip. The abduction.
This is
Can
how
you-
you say in the exam.
Please give the values, no?
You've examined the child, no? So you have to say whatever, like abduction restricted means say 20 degrees on this side compared to 40 on the other side or whatever.
Ma'am,
You
I'll
can't
start
just-
from the beginning. Like first, I'll start with the to rule out any fixed deformities.
So whatever it is you say,
Yes.
हाँ बोलो.
So first, sir, we'll rule see if there is any fixed flexion deformity or
We'll
not.
see nahi. Is it there or not?
No, sir. Sir, there is a fixed flexion deformity of 10 degrees on the. इसको ऐसा करो. नहीं, नहीं, नहीं.
नको राहू दे.
So always speak when you are doing what you are doing now. What
Ma'am,
are you flexing?
The patient is lying supine on the.
Which
bed.
side is affected side?
Right side is the
So
affected
what are
side.
you doing now
So
when
I'm
you are
flexing the left side.
So do that. Do that and speak what you are doing. And what is the name of
Ma'am,
the test?
The name of the test is a Thomas flexion test. I'm keeping my left hand under the lumbar spine of the patient to obliterate this. Yes. While flexing the left-sided hip, I'm seeing whether the space under the lumbar spine is being obliterated. See that? Sir, at this angle there is 10 degree of flexion deformity of the hip.
So on inspection you had said that there is no exaggerated lumbar lordosis.
On inspection it was not like
Then now you are saying in palpation. So what angle where you are saying what is 10 degrees?
From the long axis of the femur and the horizontal of the
Actually from here we can't make out anything. Doesn't look like.
ठीक है. आगे. Then next.
So the range of motion of the hips. So left side we can measure like this. Right.
Can nahi. 6 movements of the hip.
Flexion
So
is
now flexion deformity of 10 degrees
flexion
with
deformity of
further
10
flexion
degree.
up to
Further
whatever
flexion up to 150 degrees is possible on the right side.
Which is equal to the opposite side.
Yes, which is
Okay.
equal
So
to the
say
opposite
that
side.
in the fast. हाँ.
And extension bilaterally is about 0 to 50 degree.
If there is flexion deformity,
Arey
can you
Baba.
have extension? So you can never have. So don't make this mistake. If you are saying there is a flexion deformity, means the limb is in 10 degrees flexion, it cannot go into extension. Okay?
Okay, next. 6 movements of the hip, fast.
Sir, abduction on the right side is restricted to 30 degrees. Left side it is 40 degrees.
So there is 30 degrees of abduction in this case.
Yes.
Can you demonstrate?
See the.
This is 30 degrees. This is 30 degrees.
Yes.
How do you stabilize the pelvis?
Sir, we keep one thumb over the anterior superior iliac spine of the right side and one middle finger and other fingers over the ASIs of the opposite side. And gradually.
Stabilize the pelvis with one hand.
Yes.
And then abduct the hip
Abduct the
till
hip.
the time the pelvis start
Pelvis
tilting.
starts moving.
Stop at that level with a goniometer, measure the angle which it makes with the vertical line.
Or yes.
All right. One easier thing to do. Beta, thoda sa ithe madhe jates beta. Okay. So it's important to stabilize the pelvis. Sometimes it is difficult when you are doing on the ipsilateral side. So what you do is widely abduct the other side across the side of the table. All right. So in which case this is stabilized there. All right. And then try to move. So I don't think that there is any abduction possible here. See that? There is just no abduction possible. So there is 30 degrees of, see that? Her entire pelvis is moving. So with the pelvis stabilized by widely abducting the other side, there is just no abduction here possible. Right? So again, whatever you are saying should follow logic. You are saying that, so you are saying that she was unable to sit cross-legged and she was unable to squat. And then having an abduction of 30 degrees doesn't make sense. Alright? So this is hardly 10 degrees of abduction. It's a very stiff hip that she is having. Again, 150 degrees of flexion. Can you demonstrate 150 degrees of flexion? So then with this, she should have been able to squat. Again, it doesn't make sense that you are saying that she is unable to squat. Go ahead. Rotations.
Sir.
So abduction is only about 0 to 10 degrees. Yes. Adduction.
Sir, adduction is normal in both, about 0 to 30 degrees on both sides. Internal rotation on the right side is 0 to 5 degree in extension, and on the left side it is about 0 to 40 degrees. External rotation is about 5 to 10 degrees on the right side and about 0 to 30 degrees on the left side.
Okay. Measurements?
So, on measurements, for the apparent length, there is no apparent lengthening or shortening. Measurement of true length, there is a shortening of around 0.5 centimeters on the right side. On measuring the base of the branch triangle, I have come to the conclusion that the shortening is supratrochanteric shortening.
Okay. Next.
Should be quick. There is a supratrochanteric 0.5 centimeter shortening as measured by Bryan's triangle, Nellton's line, and that's it.
This is a very standard hip case. It should flow 1, 2, 3, 4. Just finish it off.
Special tests, anything, gait.
On special tests, ma'am, Trendelenburg's sign is positive. Trendelenburg sign is positive.
Okay.
So
we have already demonstrated in the last slide. Yes. So what is the gait in this case?
Sir, the gait is a.
Hello, sir.
Gait is a Trendelenburg gait.
Is it?
It lurches.
आई जरा चालून दाखवता तिला जरा. हाँ, या. There is a very mild Trendelenburg lurch.
That there is mild lurching on the affected side, but.
All right.
So I would say there is a mild antalgic gait.
Yeah.
So what are the features? How do you make out an antalgic gait? What is the classical
the
feature of antalgic gait?
Sir, in case of an antalgic gait, the stance phase will be reduced.
Yeah, so the child
While-
takes the weight of the affected limb as early as possible. Okay, go ahead. For want of time, we'll just go ahead.
What is the diagnosis? What will you do?
Sir, my diagnosis is a 10-year-old female with right-sided Perthes disease of 3 months duration.
I say this is an infective arthritis, a TB hip. What are the points against a TB hip and in favor of Perthes?
Sir, from history, there is no history of any night pains or any evening rise of temperature.
What
There
else? On examination, what are the findings against a Perthes hip? Which movements are restricted in a TB hip and which movements are restricted in a Perthes hip? What is the classical limb attitude in a TB hip versus the classical limb attitude in a Perthes hip?
Sir, in a TB hip, the classical attitude will be a flexed, abducted, and externally rotated.
Why is that position taken?
Because that is the position in which the hip occupies its maximum volume, and so keep it.
And what happens in Perthes hip?
Sir, in Perthes, Perthes, sir, there is a limitation of the abduction and internal rotation.
Okay, go ahead. What will you do next?
Sir, I'll get X-rays of pelvis with both hips, anteroposterior view and lateral view of the right side.
So what will you expect in the X-ray if you can go
Yes,
on
sir,
talking?
sure.
Describe the X-ray findings. In a Perthes hip, what would you expect to see?
The X-ray picture proceeds in like 4 stages. So first stage is the stage of avascularization, in which the ossific nucleus becomes more dense, and next stage is the stage of fragmentation.
That's it, just becomes dense. Any other findings in the avascular stage?
There is loss of
Also,
height
can
of-
you subdivide the avascular stage into early avascular necrosis and late avascular necrosis?
Sir, in early avascular stage, the physis height is not lost. In the advanced avascular stage, there is loss in the height of the physis.
Good. What else would you expect to see in the late avascular necrosis stage? By the way, what is the staging called, what you are describing?
Sir, it is Waldenstrom staging.
Is it Waldenstrom? Are you sure?
Yes, sir.
Radiologically, what is it? What classification?
Ma'am, Cateral.
No. So what he is asking is that the early 4 stages are Waldenstrom stages.
Yes.
He has subdivided into early and late. So what is that staging called?
Elizabethtown classification, have you
Right?
heard of?
So for everyone, the 4 stages are by Waldenstrom stages. It is subdivided by modified Elizabethtown classification into A and B of all stages. All right? All right. So can you describe this X-ray fast?
Yes, sir. Sir, I can see a X-ray of pelvis with both hips, anteroposterior view. With acetabulum of both sides is normal. The right-sided femoral head epiphysis is a bit radiodense.
So again, don't put your foot into it. Don't start off saying acetabulum is normal. Acetabulum is not normal. If you can actually see in this case, see this is a globular kind of spherical acetabulum. You can see that there is this small bicompartmentalization forming.
Yes.
Right? It's a very subtle sign. No one is expecting you to pick it up. But don't put your foot into it by saying it is normal. Right? Next.
So I can see a radiodense epiphysis of the right-sided femoral head. It is occupying almost about 80% of the epiphysis.
What is occupying 80% of the
The
epiphysis?
radio density.
Okay, so 80% of the epiphysis is involved.
Yes.
Okay, next.
Other than that, sir, there is no.
The height of the epiphysis, is it extruded or is it contained?
So, ma'am, the lateral pillar height looks a bit less.
No. Are you seeing a loss of height of the epiphysis?
Yes. On
Okay. So the radiological features can be divided into positive and negative findings. So quickly, if you can see that there is sclerosis.
Yes.
You can see that there is decrease in height,
Yes.
right? Are there any fragments seen?
No, sir.
Okay, so that is also an important finding. So there is no fragment. Is there any extrusion seen?
Slight extrusion is seen.
Probably almost not. So if you can draw the Perkins line here and here, it's almost the same. Probably some amount of extrusion. Yes, no. Anything else? What is this? What is this sign here? What is this here? Are there any head at risk signs which are of which one of them is this?
It's a
There is a big
radiolucent area over
metaphyseal,
in the
there is a big
metaphysis.
metaphyseal cyst, right?
Yes, yes.
It's a big metaphyseal cyst which is formed. Okay. Okay. So you have a hip which is having sclerosis, loss of height with no fragmentation. So which comes to which stage?
Stage 1B.
Okay. So as he rightly said, it is stage 1B, which is by the Elizabethan classification. All right.
By the way, you must see the frog-leg lateral view before commenting on the stage.
Yes.
Okay?
So again, the frog-leg lateral view, if we have Raghu. Yeah. So here, probably you can see a small fragment here, but okay, I'll give you the benefit of the doubt by saying that it is 1B. So it's 1B early 2A, right? With a metaphyseal cyst, with no extrusion in a 10-year-old female. What will you do?
Sir, stage 1B, 10-year-old female with, like I will say, catarrhal stage, it's like about 3. So, the grade.
So again, so this is something which is for all delegates, it is always important. Grade and stage are not interchangeable. The staging is a chronological classification, which means that it is every hip with Perthes disease goes through a certain chronology, 1, 2, 3, 4, based on the pathology which develops, right? Grade is a prognostic classification, which typically should be seen in stage 2 and beyond. All right. So the grading classifications are the Cattrall, Salter, Thompson, Herring's classification. Right? So don't say, "Arey stage nahi to chalo grade." Aisa nahi. So they are two completely different things. All right. So I come back to the question: what will you do for this child?
Sir, I'll go for surgical treatment with femoral varus osteotomy.
Okay. So we are not treating the X-ray; we are treating the child.
We are treating, yes.
Do you think that her range of motion is something which will change your plan here?
Sir, I'll first gain the range of motion with the after having gained of about 30.
Now, how will you gain?
With traction and physiotherapy. So,
all right. So let's finish off this case. I'll summarize what he is trying to say. So she's a female child, 10-year-old, stage 1B to A, with poor range. Now, range of motion is something which is extremely important in your surgical plan. You should never operate a child who is stiff, all right? Because that is going to cause a significant amount of chondrolysis and increase in stiffness, all right? So, never operate a child who is stiff. So, first try to increase the range of motion. Increase the range of motion is by strict non-weight bearing. You can give her traction to enforce that non-weight bearing as well as to relieve a bit of spasm. You can start her on strong anti-inflammatories. You can start her on good physiotherapy. You try that for at least 2 to 3 weeks. If it doesn't improve, then take her under GA, do a good adductor release and a medial release. Put her on a Petri cast in order to improve the abduction. Now the range of motion which is important for us is abduction, nothing else. The internal rotation is not going to improve with what? It is going to improve later on, but not in the early stage, right? So we want to improve the abduction before embarking on any surgical treatment. So you give her a Petri cast for 2 to 3 weeks, remove the Petri cast, again range that hip. See to it that you are getting a good abduction of about 30 degrees before you are going to do anything to contain the hip, right? as a general rule, any age of presentation more than 7 years, especially in a female, early stage needs to be contained, because the results of surgical containment in early disease in late onset Perthes or more than 7 years Perthes are much more than conservative management. So even if there is no extrusion which is seen on the X-ray, you have to do a femoral osteotomy. What sort of femoral osteotomy are you going to do?
Varus osteotomy.
Yeah, so it's going to be, so we call it colloquially VDRO, but here the derotation is not much. It's basically a varus osteotomy which is done of about 20 degrees in order to keep it contained in the stage in which it is going to be the weakest, which is the fragmentation stage. Right? So the edge loading is maximum so that the head has a best chance of remaining globular and spherical till the time it reaches skeletal maturity. Right? So it's a femoral varus osteotomy which is going to be planned after improving the range of motion by all types of conservative means. Alright, so that is how the entire treatment is going to be. Alright? Anything else? Any other questions from the delegates?
So as he said, while decision making, you have to take into consideration the age, the stage, the range, and the grade. All these things. So age less than 6 years or so in an early stage, stage 1A, 1B, without much involvement and with good range, you can observe. But anything beyond that, you will have to offer surgery. So age, stage, range, grade, all these things have to be taken into consideration while making a decision, and only after you relieve the patient of the acute synovitis stage, that is where your range will improve. So very straightforward case, very few positive findings, but these are scoring cases, nothing here and there, but you should know everything so that you don't waste time.
So we could discuss only 5 minutes for the management. It should be much more. Right? Alright, good.
I request BOS President Dr. S.S. Mohanty to please come on stage, and BOS Secretary Dr. Swapnil Kenny sir, and Mahaguru Dr. Karkhani sir. Please come on the stage.